Hey folks, Scott Weingart here, and this is the EMCrit podcast. Today on the podcast, super fascinating topic. It's actually a journal club on one specific paper, and it's a paper on the value of end-tidal CO2 monitoring, capnography and capnometry for procedural sedation in the emergency department. Now, before we jump in, I am just going to mention very quickly the Reanimate Conference, our Resuscitative ECMO Conference, November 2024 in San Diego. You can find information on that at reanimateconference.com. And then the new course we're putting on, the only time we're going to do it live, after that it'll be asynchronous, the Out on Time course, which is a way of shift documentation efficiency and shift management such that you will leave on time and not 2 hours afterwards. And that'll make your life better in the emergency department and the ICU. So if you're interested in that, just go to guidewirecoaching.com. That is Guidewire, like the thing that comes with your central line, coaching, all one word, guidewirecoaching.com. All right, let's jump right in. So today I'm joined by Sam Campbell, the lead author of this paper published in the World Journal of Emergency Medicine. Now, this paper is from 2016. I had not come across this, and therefore I wanted to do an episode on it. In fact, my buddy Swami from EMRAP had actually sent me this paper because he wanted to do a session on it in the recordings that we do for EMRAP. And I'm like, I had not seen this paper. This is interesting. And then I looked at the authors list, and they're all my buddies from Halifax, folks like George Kovac, Dave Petrie. And I'm like, I should talk about this because I think this is interesting. So the lead author, Sam Campbell, brilliant guy, super nice. He was kind enough to talk about this. So I'll mention the essence of the paper, and then we'll have a discussion with Sam, and then I'll give you my take-homes afterwards. All right. So what they did is this was a randomized controlled trial of 986 patients in the emergency department receiving procedural sedation for all the things you'd expect, orthopedic procedures, abscess drainage, etc. Normal stuff. And what they did is they just did a pragmatic trial, meaning you just do whatever you regularly do. But in one group, they had the availability and use of end-tidal CO2. Now, they weren't that prescriptive about what you did with it. It could have just sat there and they never looked at it. We don't know. But that's the essence of the trial. Everything the same for standard care, but one group got end-tidal CO2 and the other group did not. And now what's of interest, that it will vary from your practice setting, is that the procedural sedations are done by a group of critical care paramedics. And these critical care paramedics are doing other stuff in the hospital. They help with the trauma teams. They do intra-hospital transport. But one of their jobs is to do all of the procedural sedations in the emergency department. And they receive special training. They, look at all their cases. They're probably more aggressive than you are in terms of quality assurance for their procedural sedations. And they're using all of the deep sedation drugs. Their primary medications in this study were propofol and fentanyl. And they seemingly do an amazing job of procedural sedation in the emergency department. Now, these patients were mostly getting deep sedation. And very importantly, they were received both pre-oxygenation with high FiO2 and intraprocedural oxygen. And this is absolutely key. These were not room air sedations. This was sedation with oxygen. And the results were there were no significant differences in any of the real patient safety things like desaturation or hypoxia. There was a non-significant increase in the number of patients who received positive pressure ventilation in the standard care group, but we're talking 0 in the end-tidal and 2 out of 500 patients in the standard care group. So certainly not statistically significant, certainly not anything that is a relevant difference between the two groups. Now, what were the differences between the two groups? There were more airway positionings, statistically significant, more airway positionings in the end-tidal CO2 group, and then there was more hypotension. Just a little bit more hypotension, but it was statistically significant in the end-tidal CO2 group. Now, that latter finding, for me, it's probably, yes, it's statistically significant, but it's probably just a clinical anomaly. I don't make much of it. There's some postulating in the paper. The airway positioning was not at any great number, even though it was statistically significant, that I would say this is significantly a change between the two groups beyond the statistics, clinically significant change. So for me, it was a wash. The trial did not show any patient-important benefits to end-tidal CO2 monitoring. So that is the milieu by which we will enter into this conversation with Sam Campbell. And I'll let him introduce himself, and then we'll go right into it. I'll start with a question I always start with, which is, who are you and what do you do?
I'm Sam Campbell. I'm a research director in emergency medicine at the Charles Keating Emergency and Trauma Center in Halifax. It's a sort of mid-sized city, probably about 400,000 or 500,000 people. We see about 80,000 visits a year. It's Canadian, which means we're completely dysfunctional. We have more inpatients than we have emerge patients in our department. A lot of the shifts, more patients in hallways than you do in beds.
Yeah, that sounds a lot like America. So I think we're all in the same space. Now, Sam, the reason we're talking is this amazing randomized controlled trial you did on end-tidal CO2 for PSA. And I guess the first question I would ask about that is, what was the reason you did the trial? And then did you have any inclination on how it was going to turn out before you started?
Really good opening questions. Yeah, the message we got from the paramedics when we bought this new machine for them was, we don't think it makes a difference. You're just trying to complicate our lives.
I hear that for the medics. What about you, Sam?
Yeah, when on the occasions when we don't have medics and I'm doing procedural stations, I'm not as good as they are. I don't do as many procedural stations with them. So I do bow to their superior knowledge. I didn't find it useful. I find, if you look at the research, there's a lot of so what attached to tidal capnography.
That's very fair. All right, I'm going to ask some clarifying questions about the study itself. I have a few of those. And then I want to talk about our hypotheses and theories for what we actually see in the paper. The way it was in the tables seemed to be that the propofol was in a microgram per kilogram per minute form. That's how it was actually reported. Were they giving propofol infusions or were they giving propofol boluses and you just decided to report it as that?
Yeah, no, that's decided to report. We didn't prescribe a particular dose like the other studies did. But when we were calculating it, we have a procedural station registry and we got the dose, we got the duration of the sedation, and we calculated a dose.
So they weren't giving boluses of propofol?
They were giving boluses, yeah.
And did they have any standard operating procedure for that in terms of a starting dose and how much additional they gave? Or was completely, I know it was up to the individual medic for that sedation, but did they have standard operating procedures for how they actually went about
it? There were standard operating procedures, but they're quite broad. It was 20 to 40 milligram boluses and then titration after that.
That makes complete sense. All right. Here's the one that I kept looking for in the paper. And I'm like, how could this not be here? Because it seems such a crucial piece of information. What depth of anesthesia were they shooting for in these patients?
So that was left to the discretion of the paramedic. So this was very much a pragmatic study. We didn't, the only patients they couldn't enroll were patients that couldn't consent. That's why we had 20, we didn't restrict it to ASA 1s and 2. We said, whatever you do in your job, we want to see if ETCO2 is going to help you.
Oh, no, I understand that completely. What I'm referring to is, even as a reporting rather than a qualification for the study, I have no idea what they were doing. Were they doing deep sedation? Were they doing just general procedural sedation where it wasn't deep sedation? Were they doing general anesthesia for the actual period of time the patient was getting their orthopedic reduction, which is what most of us are doing? I have no ability to judge. If this was a study of light sedation, then of course everything makes sense.
Yeah, no, it wasn't light. We do have that data, and you're right, we didn't enter it. We have we try and get overshoot as well. So we try and ask them before and afterwards, this is what you intended and this is what you achieved. And we didn't put in the numbers because there was very little overshoot. But I would say 90% were deep sedation. And when I say deep sedation, that's a euphemism for general anesthesia in our department.
All right. So
these short procedures, they're very short procedures.
Because I've seen places, and it sounds like this is not your place, but I've seen places where routinely their reductions are done with the patients writhing in pain because they are deep sedation. That's what deep sedation does. Deep sedation is still responsive to pain. And then the patients don't remember it, so everyone's happy. But you hear the shouts from the room. But it sounds like you folks are not.
Yeah, and the other thing is you need relaxation for procedures. And same, if you're draining someone's perianal abscess, you don't want them writhing around and jumping. Yeah, we're talking brief general anesthesia.
Okay, great. And then define hypotension. Because I didn't see that defined in the paper.
Okay, so we defined hypotension. Hypotension is very difficult to define because it's quite often relative. So we defined it as a systolic blood pressure less than 100 or less than 85 if the baseline was less than 100.
Okay.
And that was in any reading during the procedure.
Got it. All right. And then the paper said almost all of these patients had non-rebreathers. That brings up a further question now. So were they just putting it on and not turning it on?
They were putting it on and having it at a very low flow rate. So it wasn't at the sort of non-rebreather rate.
Okay. So that's interesting. We'll get into it on the theory section, what I think about that. All right. And then last question for the clarification part, why this journal? Because I look at this paper, this is like one of the biggest RCTs on this. And then I look at this journal and I worry something's going on that I'm not seeing.
You should worry. It was obviously submitted to annals and they rejected it with some very reasonable points. And I was actually looking through my records. Unfortunately, I purged my emails a couple of years ago, so I don't have a record of their complaints. But it's a slightly messy study. There's no blinding. It's hard to blind whether you have information or don't. Of course. We didn't gather CO2 results, and the patient either got the machine or didn't get the machine. Whereas in the DEECH study, they all got the machine, but the provider was blinded. I've published a couple of times in this journal, and it is a journal I've used for stuff that I didn't want to put too much energy into. Mm-hmm. But I've felt a bit of sense of loyalty toward them because they'd actually be good to me, and I want to support them. Having said that, I would far rather have had this in academic emergency medicine or annals.
Yeah.
But I don't think we sent it to academic emergency medicine. But I think I had a lot going on at the time. So I was submitting stuff to different papers and I sent it to a target that was going to be a full essay.
You're like, at some point, I just want it accepted. So I hear it. I've been there. All right. That's the clarification portion. Let's get into the theory here. The way you folks discussed the findings in the discussion section of the paper makes me feel, and the discussion I've had with you, Sam, makes me feel like I have a different vision of what the end-tidal CO2 monitor is for than might have been embodied by your program. And potentially maybe I'm the outlier. Maybe everyone's thinking the way you guys do and I'm the odd one out. But for me, the only purpose, like the only thing I even look at an end-tidal CO2 monitor for during procedural sedation is as an apnea monitor. And even flatline doesn't tell me I must do something. It's simply like, all right, apnea has now started. And at some point, I could choose to intervene or not. But there's a lot of discussion in your paper and in the conversation we've been having, Sam, that hypoventilation is somehow what we're looking for on this monitor. And that's something that the end-tidal CO2 lovers care about, and you don't think we need to. And I agree with you. Like, I'm right there with you. Hypoventilation, who cares? If they take even one breath a minute, that's great. I don't need to do anything on those patients. So it sounds like our focus is different. And it sounds like the focus of the paramedics may have been different. Could you speak to that a little bit?
Scott, I think that you're looking at it with the understanding of an intensivist. I think when capnometry is a test in the same way that any of the other tests. And when you have a test, you've got to say, okay, what does the finding tell us? What does what it tell us mean? And what should we do about it? You're recognizing right away that what it tells us is irrelevant. You're not looking for what it tells us. You're looking for a particular, and you're looking for apnea. The one argument is that if you throw this out into the general public, and we can talk about, there was one study looking at family docs doing this. We tend to respond to tests, whether we like it or not. We tend to respond to tests. We tend to respond to a high white count. We respond to the BNP. The one thing about tests is that tests are most reliable when they're least needed. And BNP is a great example. If you get someone who's short of breath and they're clearly asthmatic, the BNP is going to be pretty reliable. If you get someone who's clearly in pulmonary edema or congestive heart failure, it's going to be pretty reliable. And when I say reliable, it's going to be true. Where you want it is where there's equipoise. And there, the overlap is much more, and the test gets a lot less useful. And capnometry is probably the same. I often hear our residents say, yes, I agree, capnometry is probably useless. But if a patient is a COPD patient who's obese with sleep apnea, I'm going to use it. And my argument is, an obese patient with sleep apnea and COPD, all of the monitoring in the world is not going to make me think that it's appropriate to do that in the emergency department. But if you're reassured by normal capnometry in that patient, you're wrong, because that's an accident waiting to happen. And it's similarly, if it's a big wave surfer who can hold his breath for 5 minutes, that alarm is just going to complicate things. It's irrelevant. This guy's fine. This guy could probably be apneic for the whole of his procedure and he wouldn't notice it. Where you really need it is that middle group. And if you watch experienced procedural sedation, when they talk about interventions in these studies, the commonest intervention is a jaw thrust. Most of the time, you're doing a jaw thrust almost like a type A cross-carry. You're not even thinking about it. You're just doing it. Apnea is expected. It's not, I need a machine to tell me if this patient's apneic. I look at the machine. If they're breathing, they're fine. If their sats drop to 92, I really have a look to see if they're breathing. I don't need a machine to say they could be breathing. And if they're breathing, but they're breathing slowly and I'm toward the end of my procedure, I'll let that CO2 go up a bit. I don't know what it is. I don't really care what it is. If I need to, I'll do a jaw thrust. If his sets start dropping a bit, I might do some very gentle posture pressure bagging. It's really uncommon that you actually need to do that. The machine is just adding stuff that you already know, or it doesn't matter.
Hey, it's Future Weingart popping in here. Just to say, I'm not really sure, having listened to this now in real time and then listening to it for editing, that I really agree comparing tests to monitoring technology. I think while they share some overlap, they're very different things. And while I agree with Sam that BNP is virtually useless because it doesn't actually measure the patients we care about well,